Hello, welcome everyone to Surviving Sepsis 2021 updates to the management of sepsis and septic shock. Today we're pleased to have the following presenters with us: Dr. Anna Maria Crawford, Stanford Anesthesia Division of Global Health Equity, Dr. Francoise Nizeyimana from the University of Rwanda, Dr. Karima Khalid from MUHAS in Tanzania, Dr. Gaston Nyirigira from the University Hospital of Butare in Rwanda, Dr. Vanessa Mall from the University of Zurich in Switzerland, Dr. Erica Chimelski from Stanford University, Dr. Pepicho Ntamwe from Livingstone Central Hospital in Zambia, and Dr. Fred Mim from Stanford University. Before we begin, we do have a few housekeeping notes. To start, we will be using the chat function for question and answer. To access this, the button is at the bottom of your screen. Please send us all questions through the chat box and feel free to introduce yourself. If you have any technological issues, send us a message through the chat. Today's session is being recorded and your attendance is consent to being recorded, so thank you. And then please be mindful of infection prevention and control. Try to limit the number of people joining from one gathering place and practice physical distancing. And with that, I'll pass it over to our lead presenter, Dr. Anna Maria Crawford.
Thank you, Alana, and welcome everyone. I would say good morning, but I know it's afternoon for many of you. We are very happy to have you back. We had several folks join on Monday. It was a really great session. I think we had like 375 people join us, so really good discussion. Today we're going to do a case-based discussion to cover the updates. There's 93 updates coming out of the Surviving Sepsis campaign in the management of adult patients with septic shock. I want to again thank all of the wonderful panelists that we have today from all over the globe. These panelists are volunteering their time to teach others, so really grateful to them. We have already put the link to the Learning Resource Center within the chat box. So if you'd like to follow along on the LRC or Learning Resource Center, you're welcome to do so. You can also access all these materials and this video after the session on the Learning Resource Center as well. So this is the case, the learning module within the Learning Resource Center. You can see it's within the Critical and Intensive Care Medicine course, and you can see that it's module 7. I'm going to close this navigation pane and point out one other thing. Sorry, let's go back. So this is the Learning Resource Center. We're going to go into the Critical and Intensive Care Medicine course and go back to sepsis and septic shock. And we already did part 1, which is already up on the Learning Resource Center, as is the video. And today we're doing part 2. Okay, should be back in business. One other thing I want to point out to you within the learning module is this small paper clip in the upper right-hand corner here. If you click on that paper clip, you can see that you have the PDF format of the Surviving Sepsis campaign article with all 93 updates. And then there's also a respiratory care pocket card that we'll be using today. And so you can download it here. Additionally, within the Learning Resource Center, there are many active links that take you directly to open access articles. The two most prominent links are going to be this one. So the Surviving Sepsis campaign launched these updates last month in October of this year, coming out of the European Society of Intensive Care Medicine and the Society of Critical Care Medicine. They published these updates in 2 different places. So you can click here and go directly to the article. You can also click here and go to the second publication. So same updates published in 2 separate locations. Many of you sent in questions before this session asking about pediatric sepsis and sepsis in the obstetric patients. Unfortunately, the 93 updates in the Surviving Sepsis campaign did not address these two patient populations, but we have listed for you pediatric updates here and also resources for managing sepsis in pregnant women, both here and here. So I'll let you click on those independently and you can find those resources. Just a recap from part 1, we talked about screening and early treatment for sepsis and septic shock. We talked about the initial resuscitation. We talked about mean arterial pressure, admission to intensive care, infection and source control, and we talked about hemodynamic management. So that was all discussed on Monday. Today is part 2. We will be discussing ventilation, additional therapies, long-term outcomes, and goals of care. So with that, I'd like to get us started on our case update. And I'm going to ask Dr. Erica, would you mind reading our case update from Monday?
Sure.
Thank you.
So to recap from part 1, Mr. G is a 66-year-old male with no past medical history who presents with septic shock associated with abdominal pain and diarrhea. He has received IV fluids, antibiotics, and several investigations were ordered. He is on oxygen and vasopressors. His CT abdomen pelvis was consistent with a diarrheal illness, but did not demonstrate an abscess or other surgical indication. The ICU nurse now calls you because Mr. G has emesis with large volume of bilious liquid. He's now short of breath and requiring 15 liters a minute by non-rebreather mask. She also states that the laboratory called to report additional investigation data. You ask for a repeat chest x-ray to be performed at the bedside. You arrive in the ICU to find Mr. G on 15 liters a minute of oxygen by mask, short of breath, ill appearing, and with increased work of breathing. He's awake and responsive, but talks in 3 to 4 word sentences. Noradrenaline is infusing at 0.8 mics per kilogram per minute, and vasopressin is infusing at 0.03 units per minute. His vital signs are now respiratory rate of 34, heart rate of 122 beats per minute, temperature of 38, blood pressure of 100/62, and he is saturating 91% on a pulse oximeter. His labs, he review, and his white blood cell count is 22, his hemoglobin is 8.4, hematocrit 25.5, platelets of about 200. His metabolic panel reveals a sodium of 141, a potassium of 4.1, chloride of 108, CO2 of 18, BUN 34, and serum creatinine elevated at 180. His transaminases are mildly elevated, AST 63 and ALT 24, and his coagulation factors are INR of 1, PT 13. His chest x-ray shows no pneumothorax and hazy bilateral lung opacities. There are small bilateral pleural effusions as well with compressive atelectasis. In terms of microbiologic studies, his blood cultures are now growing gram-negative SLI, and his respiratory culture is pending. His urinalysis was negative, so there is no urine culture pending.
Wonderful. Thank you, Erica. So Mr. G looks fairly ill. He's tachycardic, tachypnic. His oxygenation is mediocre at best. He's got definitely shows some renal dysfunction and some other abnormalities in his labs. So he seems pretty sick. I would call him septic and septic shock because he's on vasopressors. I'm wondering, Dr. Francois, we're going to start off with this section on ventilation. Would you mind to read the objectives? And I want to again point out to the learners that instead of just learning this material, we actually want providers to change their practice. So when we go through these modules, remember that we need to learn the material, but we also need to adopt some of these guidelines into our practice so that we can improve patient outcomes. Francois, are you able to read our objectives for this section?
All right. So ventilation objectives: understand risks and benefits of hyperoxia from excess of FiO2 delivery. Choose appropriate oxygen delivery device for acute hypoxemia. Calculate the appropriate tidal volume for any patient. Define ARDS. Recite the acceptable upper limit for plateau pressure, describe the difference between peak inspiratory pressure and plateau pressure, describe recruitment maneuver and recite when they should be used, describe when prone positioning is employed for mechanically ventilated patient, recite the recommended duration for prone position, appropriately prescribe neuromuscular blockage for patient with sepsis-induced ARDS, understand when ECMO is indicated for patient with sepsis-induced ARDS.
Thank you so much. And for those who don't know these abbreviations, the NMBA is neuromuscular blocking agents, and VV ECMO is veno-venous extracorporeal membrane oxygenation. So we'll talk a little bit more about that. Okay, let's keep going. So this is the first question. This is for the learners, for you in the audience. Mr. G's pulse oximeter is reading 88%, even though he's on 15 liters per minute oxygen by non-rebreather mask. What is the appropriate next step, the most appropriate next step? So A, immediate intubation and mechanical ventilation. B, referral for ECMO. C, blood transfusion. D, high flow oxygen therapy. Or E, no intervention is needed at this time. You can answer in the chat box. We prefer that you would use the poll that's been launched. So let's see, we've got some answers coming in, which is great. Okay, so that's about 45 seconds. We're going to end that poll. And it looks like there was pretty close between A and D, so intubation versus high flow oxygen therapy. I think either could be considered. I think those are reasonable answers. I think the patient is awake and the patient is able to speak only in 3 to 4 word sentences. So let's see, Dr. Moll, would you mind reading this quote? And this quote comes directly from the guidelines for the updates and management of sepsis.
Sure.
Thank you.
Patients who are undergoing mechanical ventilation in the ICU often receive a high fraction of inspired oxygen and have a high arterial oxygen tension. The conservative use of oxygen may reduce oxygen exposure and diminish lung and systemic oxidative injury. The evidence for the use of conservative oxygen targets generally defined as a PaO2 of 55 to 70 millimeters of mercury and SpO2 of 88 to 92, and therapy in patients with sepsis is limited.
Okay, so I think that the answer to the question could be A or D, and I think it depends on the resources that are available to you. But high flow oxygen therapy has been used extensively and in some cases can prevent intubation. So if you have a high flow oxygen therapy, I think that that is a reasonable place to start for Mr. G. If that's unavailable to you, then you could consider doing non-invasive, which we'll talk about in a minute, or you could consider doing intubation and mechanical ventilation. So there is insufficient evidence to make a recommendation on the use of conservative oxygen targets in adults with sepsis-induced hypoxemic respiratory failure. So what this quote that Dr. Moll is saying and what this recommendation, this is directly out of the guidelines, is saying is that keeping the SpO2 at 88% may not be the best thing for Mr. G, even though there is some debate on an acceptable safe limit for SpO2. Dr. Moll, I'm going to call on you again because I know you know this well.
Which of the following?
Thank you.
Which of the following is a potential complication with excessive FiO2 delivery? Is it A, oxidative injury to lungs, B, systemic oxidative injury, C, vasoconstriction, D, cellular apoptosis, or Where am I? E, all of the above.
So the debate on where to keep the SpO2 largely originates from this concern over having too much oxygen versus having too little oxygen. So there are complications from giving too much oxygen. So which of these is considered one of those? Good. Okay, so we'll end there. Looks like a large majority of you said all of the above, which is correct. So if you're in the Learning Resource Center, you can actually click on the question box and it will take you to an open access article that discusses this. And I'm wondering, Dr. Mall, if I can't get you to walk us through this curve here.
Absolutely. So on this curve, you see on your y-axis, your, let me just see, you see on your y-axis, your outcomes, your worst outcomes, and on your x-axis, you see your PaO2, your partial pressure of oxygen, in millimeters of mercury. And you can see how the sweet spot of good outcomes and is around 250 millimeters of mercury. And it's a U-shaped curve. What that means is that if you go either too high or too low, your outcomes will get worse. And just as a reminder, you can calculate your partial pressure for oxygen at alveolar levels with your alveolar air equation. But when you go to the lower side, you will cause pulmonary hypertension by hypoxic vasoconstriction. There will be an adrenergic response, and you will eventually get to tissue hypoxia. On the other hand side, if you give too much, it's also not good. So there is vasoconstriction, there's oxidative stress. The high oxygen content will produce oxygen radicals, which then will lead to basically an inflammatory and oxidative stress response that then will be damaging to tissue and will lead to cell death, apoptosis, and that of course leads to pulmonary damage. So you really want to be in the sweet spot.
Thank you, Dr. Mall. That's an excellent explanation. So the answer to this question would be all of the above. So we don't want our oxygen levels too low, and similarly, we don't want them too high. So this next question I'll read. Although there may be a lack of clear evidence and consensus, which one of the following oxygen goals is recommended for adult patients with septic shock, according to the World Federation of Societies of Anesthesiologists, the Australian and New Zealand College of Anesthesia, and Lifebox? So which of these SpO2 goals do you think is most appropriate for adults with septic shock, according to these organizations? So great. We'll end there. There's some good answers, but it looks like the answers are mixed, doesn't it? So SpO2 greater than 88 is a consideration that we use when patients have COPD or emphysema, but not necessarily patients with septic shock. The majority, only by slight, 55%, answered SpO2 equal to 92 to 95%. And the other larger percent was SpO2 greater than 94. So again, you can click on the question box to find the article or resource that supports the question. So this is oxygen therapy for limited resource settings that is put out by several organizations, including WFSA, ANSCA, and others. And if you come down to this confirm hypoxemia with a pulse oximeter section, you can see that this fourth bullet point here says adjust oxygen to a target of SpO2 greater than 90% in adults and children. However, if signs of multi-organ failure, including shock or alteration in mental status, your target should be greater than 94%. In pregnant patients, the target should be 92 to 95%. So from that, the answer would then be D, greater than 94%. Okay, so remember, Mr. G is not doing very well. He's breathing quickly. His oxygen levels are 88%, and he's on 15 liters per minute. Dr. Erica, do you mind reading this next question?
Sure.
Thank you.
So you decide you need to intervene and better support Mr. G's oxygenation and breathing. The nurse suggests intubation and mechanical ventilation. What is your best response? A, hand me the laryngoscope. There's no time for sedation. B, let us try something less invasive, such as high flow oxygen therapy first. It helps with oxygenation and may improve his rapid breathing. C, please set up the BiPAP. I think he's retaining carbon dioxide. Or D, I will be in my office. Call me if he stops breathing. So it seems like most people would go with trying high flow oxygen therapy first.
Yeah, great. And I think that is a reasonable next step. And I would say that's the answer. Dr. Erica, I'm not sure if you've seen this infographic before that comes out of the BMJ journal, but it goes through options for respiratory support. It says for COVID-19, but I think a lot of this would apply to hypoxic respiratory failure. Have you seen this infographic before?
To be honest, I'd seen it for the first time in this presentation. The specific infographic, yeah. Yeah. So I think it's really a helpful one. But you have a person with respiratory distress. You do it tells you to do a focus history and exam. It tells you to consider blood gas testing if available. But I think the big difference is, is it just hypoxemia, or do they also have hypercapnia? So which patients, from all the panelists, which patients are at risk, and the learners, you can type the answer in the chat box, which patients are at high risk of hypercapnia? You can type it in the chat box. Who is at risk? Good, Maria, Christina, and Alexi. Perfect. COPD patients with emphysema have a higher risk of retaining carbon dioxide and becoming hypercapnic. So if the patient has hypoxemia, you can move down to this, and it says if they have hypercapnia, that actually puts them over here in type 2 respiratory failure. These are your COPD patients. And so the oxygen delivery devices that are most useful for COPD might be Venturi mask or non-invasive ventilation. If you remember, Mr. G doesn't have much past medical history. I think he has a little bit of high blood pressure. So he would be hypoxemia without hypercapnia, which pushes him over to type 1 respiratory failure. And you can see now we have several different devices that you can use in type 1 respiratory failure. You can start with nasal cannula, you can move to simple mask, you can go to reservoir bag. And so he's already gone through all of these. Right now, he's on 15 liters per minute flow on a reservoir bag. And you can see that's the max flow. So he really needs to receive additional support. So the two things that he can do short of intubation and mechanical ventilation is high flow nasal oxygen or CPAP. If you want to access this infographic, we actually think it's a really good one, not only for
COVID, but also for hypoxemic respiratory failure. You can actually click on this image within the Learning Resource Center. You can also read the full article online. The link is here, and you can see additional infographics that journal puts out by clicking there. Okay, Dr. Erica, do you mind reading the recommendation from Surviving Sepsis campaign number 47?
Sure. For adults with sepsis-induced hypoxemic respiratory failure, we suggest the use of high-flow nasal oxygen over non-invasive ventilation.
Great. So they're saying that you might want to try high-flow oxygen before doing something like CPAP. The problem becomes high-flow oxygen is not available in all settings, but if it is available, it's recommended to try that before. And then Dr. Erica, if you don't mind continuing, there's a few quotes from the guidelines themselves. We'd love to hear about those.
Sure. High-flow nasal cannula is a non-invasive, high-concentration oxygen delivery interface that confers warming and humidification of secretions, high flow rates to better match patient demand, washout of nasopharyngeal dead space, and modest positive airway pressure effect. The single inspiratory limb of high-flow nasal cannula allows for airflows as high as 60 liters per minute to achieve inspired oxygen fractions as high as 95 to 100%. However, high-flow nasal cannula is less effective at reducing work of breathing and supplying a moderate or higher level of PEEP. Next, non-invasive ventilation use can be associated with development of complications, including increased risk of gastric insufflation and aspiration, facial skin breakdown, excessively high tidal volumes, as well as patient discomfort related to inability to eat or effectively phonate during therapy. So this specifically referring to CPAP or BiPAP. And lastly, although the quality of evidence is low, the benefits of a trial of high-flow nasal cannula for the sepsis patient with non-hypercapnic progressive hypoxia over non-invasive ventilation seems justified. Patients requiring high-flow nasal cannula for acute hypoxemic respiratory failure are at high risk of requiring intubation. Therefore, such trials must be accompanied by careful surveillance for ventilatory failure.
Great, thank you so much. So I would just like to build on the concept that high flow oxygen therapy, although becoming more available, is not available everywhere. So I'd love to hear from Dr. Francois and Dr. Papicho, if possible, if high flow oxygen therapy is available in your setting.
Not yet in Rwanda.
Not yet in Rwanda. Okay. And so would you at this point try to do non-invasive, or would you try to intubate this patient?
So depends. If it's a patient who is cooperating, you can use non-invasive. But sometimes you have a patient who can't really tolerate non-invasive because maybe too sick or not cooperating. So that patient, you go straight to intubation.
Right. Yeah, I think that's completely reasonable. If the patient is too sleepy or the patient is too anxious, they may not tolerate that tight-fitting mask of non-invasive. You can try it, and if it doesn't work, then you need to move quickly to intubation, isn't it? I made a comment in the chat box. I want people to understand that high flow oxygen therapy or high flow nasal cannula actually requires a specialized machine or device that heats and humidifies the flows. The flows are very high. They can be from 30 to 70 liters per minute. It also requires a special nasal cannula interface for the patient's nose. So when we say high flow oxygen therapy or high flow nasal cannula, it is definitely not a normal nasal cannula with just really high flows. So it's a specialized device and specialized cannula. So I think that's important for people to understand, especially if you haven't used it or seen it before. So there's insufficient evidence to make a recommendation on the use of non-invasive ventilation in comparison to invasive ventilation for adults with sepsis-induced hypoxemic respiratory failure. So this is a recommendation non-recommendation, which is basically around this concept that Dr. Francois was just describing. You can try it, but if we don't know if it's better or worse than going straight to intubation. Dr. Francois, do you mind reading this next quote from the guidelines?
Of course not. So non-invasive ventilation can cause mask-related discomfort, no aspiration event. Studies have suggested that non-invasive ventilation failure is an independent risk factor for mortality. If non-invasive ventilation is used for patients with sepsis-associated hypoxic respiratory failure, we suggest monitoring for a narrow reduction in work of breathing and close monitoring of tidal volumes.
Great, thank you. We have some really excellent questions in the chat box. One I'd like to address specifically: can low dose morphine be used in a patient that is agitated from hypoxemia? I actually say no, because morphine, although may make the patient less agitated, can actually cause respiratory depression and also cause the patient to become more sleepy. And somebody in this amount of distress, who's breathing very, very quickly, actually needs that high minute ventilation to meet their gas exchange needs. So that's one reason why I wouldn't use morphine in an awake patient who's struggling to breathe. Secondly, this patient has a bit of renal dysfunction. Morphine has active metabolites, especially in renal insufficiency, that actually contribute more to respiratory depression than it does to anxiolysis. So if you're going to use morphine, I would say at that point, that patient probably needs to be intubated, because they won't have the same ability to respire and exchange gases if you depress their respiratory drive. Alexi's asking if we can use dexmedetomidine, or he or she, sorry, Alexi, does use dexmedetomidine. And I think that's also something that we use commonly. Unfortunately, dexmedetomidine may not be available in all settings, but dexmedetomidine is an amazing sedative that does not depress respiratory drive. So if you have dexmedetomidine, that's an excellent option. Do any of the other panelists have any other opinions or things to say about using morphine in a patient like this?
I actually would second you, Anna. This patient clearly needs a very high minute volume to sustain, and so I would not use morphine. One of the learners suggests benzodiazepine. In my practice, I commonly do not use benzodiazepines. I only use it for withdrawal, alcohol withdrawal, for example, or for patients with seizures. And this is because it has been associated with a higher rate of delirium when used in the ICU. So, I think what I would do is also I would address his respiratory status first. Clearly, this patient, cannot sustain this for a long time. So I would use non-invasive ventilation, or I would at this point intubate him. And then go with sedating him, as appropriate when he's intubated.
I completely agree. I'm not sure, Erica or Francois or Papito, do you have any other thoughts around this?
Yeah, no, I would third your opinion. I wouldn't want to suppress respiratory drive with morphine. And in my practice, I commonly use dexmedetomidine as well in that situation. But I think if that weren't available, intubation would be the next best option if a patient's too agitated.
Yeah, I think for Yusuf and Isabel, I think that if you have a patient who's in extreme distress from a hypoxemia and respiratory distress standpoint, and they're agitated, the best course of action is probably to be intubated. If the patient, like Mr. G, who we're discussing now, is awake and oriented and actually still speaking to you and not agitated, you can try high flow oxygen, you can try non-invasive ventilation. But once the patient starts to have alterations in mental status, I think this happens in my hospital, but altered mental status is a sign of shock. It means that the patient is so sick, they may not actually have good enough perfusion. And so altered mental status is one of the SIRS criteria, right? So in that situation, it really signifies your patient is getting worse. So I think in that situation, we would need to intubate. I also try to avoid benzodiazepines, except in the situations in which Dr. Moll described. Benzodiazepines do 100%, they increase ICU delirium and they make sometimes patients more agitated. Additionally, even though not classically taught as respiratory depressants, they are respiratory depressants, especially when combined with some other medications. I've given 1 milligram of a midazolam to a patient and seen them completely pass out. So if you were to sedate this patient, and they did suffer from respiratory depression or further alteration in their mental status, you're going to move to intubation anyway. That would be the next step. And so you may as well be prepared for that versus precipitating that event. Great. Hopefully that answers your question. Those are great questions. Thank you for putting them in the chat box. Okay, you successfully placed Mr. G on high flow oxygen therapy 20 minutes ago. Now the nurse is calling you again and states, "Doctor, the patient is not waking up and his oxygen is low." You rush to the bedside to meet the nurse and successfully intubate the patient using a rapid sequence induction technique. Mr. G is now on mechanical ventilation and sedated using infusions of midazolam and hydromorphone. Okay, so this question is, I'm going to give you a little bit more time, but the question is, what parameters settings will you use on the mechanical ventilator? So in the chat box, I don't think that we have a poll for this. So in the chat box, I want you to put what mode, what tidal volume, the respiratory rate, the FiO2, and the PEEP. We all have to write these orders. And so I'd love to see what ideas you have, and I'll give you a few more times, a bit more time. I also want to welcome Dr. Radiography. Thank you for joining us today, another amazing panelist. So we're happy to have you.
Thank you. I'm glad to be here.
Yay. Okay, Alexi, volume AC, so that's a mode, great. How about tidal volumes or other modes? How about respiratory rates? If you're taking care of these patients, you have to make these decisions on how to program the ventilator. And this is often a point of confusion when we're in training. So there's lots of different, we could spend 2 hours talking just about ventilators. Unfortunately, we have to cover many other things today. So we've got the mode. What tidal volume will we set? Okay, good answers coming in. Love it. Good tidal volume, 6 milliliters per kilogram. Breaths per 16, I'll let Dr. Vanessa Moll talk about that. FiO2 100, respiratory rate of 25, PEEP of 5, and 10 if larger. Okay, interesting. Lung protective strategies, respiratory rate of 12. Okay, great. So we'll go ahead and jump in, and I'm going to call on my panelists to help me answer these questions. The mode needs to be a control mode. A control mode is where you set a respiratory rate. So you can set a volume control mode, you can set a pressure control mode. Typically, we would set a volume control mode. And the reason is if you set a pressure, but the lungs are very stiff, you may not get enough tidal volume for gas exchange and ventilation. So most people would do a control mode using volume. So that could be CMV or ACVC. So assist control, volume control. And most of the studies for patients that have ARDS were done with ACVC, or a controlled tidal volume. Tidal volume, most of you said 6 milliliters per kilogram, which is mostly correct, but we want to make sure that when we do that 6 milliliters per kilogram, we're using kilograms that are the ideal or predicted body weight of that patient. Sometimes we have patients that are very overweight, and sometimes we have patients that are very underweight. Our lung size does not change. If I put on 40 pounds or 25 kg, my lungs don't get any bigger. So it really needs to be predicted body weight. That body weight, there's calculators that you can use. It changes depending on whether it's a male or a female, and it changes depending on the patient's height. So you need to actually calculate your patient's predicted body weight. Respiratory rate, we had several different answers. We have a respiratory rate of 12. We have a respiratory rate of 12. We have a respiratory rate of 12. We have a respiratory rate of 25, of 16. So it seems like a lot of confusion perhaps on where to set the respiratory rate. And I'm going to ask Dr. Vanessa Mall and Dr. Erica, Dr. Radiot, how do we determine what the respiratory rate should be?
You know, I think it's a very good question, and I think it's always confusing for learners. So in this case, this is a very sick patient. So this patient is not our patient that comes to the operating room for an appendectomy, for example. So this patient is in shock and respiratory distress, and he is breathing at a very high rate that is for him not sustainable for a long time. So his respiratory rate, I believe, was around 30.
Yeah, it was
over.
So,
right.
Mm-hmm.
And so you want to match the minute volume of the patient. So I would go with the learners 6 mil per kg of predicted body weight, and then I would set the rate about where the patient was breathing. So I would set the rate initially at about 30, and then adjust my ventilatory settings from there. I agree with you that I wouldn't use a pressure control, because lungs are stiff, but also if your compliance improves, you can go into the other direction, and then you can give too much volume to the patient and cause volume trauma. So while pressure control is a really great mode, it requires a lot of focus on the patient and on the ventilator to be able to adjust and keep the patient in a safe ventilation strategy. Great.
Excellent explanations. Erica, Radiot, Francois, do you have anything to add?
I think also I would, it's not this patient's context, but it depends on what's going on with the patient before you intubate them, to an extent where you'll set your respiratory rate too. Like if someone has just experienced a cardiac arrest and you get ROSC, you would expect them to be very acidemic. So you would also want to set that respiratory rate very high, probably at 30, above 30 to start out.
Yeah, that's an excellent point. And I would argue not just after cardiac arrest, but even in patients with asthma, or patients that are in extremis where they are breathing really fast for a long time, eventually they start to tire and that carbon dioxide starts to build. And so that patient is at risk for acidosis, a respiratory plus a metabolic acidosis. In septic shock, it's often a metabolic acidosis, but it can be worsened if that respiratory rate isn't kept high to compensate. So that CO2 and acidosis is a real threat for septic shock patients. What if the patient's respiratory rate before intubation is greater than 35? I think I would do what Vanessa Mall did, which is set it at 30, and then you have to reevaluate with blood gases if available. If not available, then you just set the rate as high as you can without getting breath stacking. So the risk of setting the rate really high is that the patient's not able to completely exhale before the next breath is pushed in. And so if you can't completely exhale, then your breaths start to stack and you start to get barotrauma. So you have to look at the waveform on the ventilator. So a little bit more sophisticated concepts, which unfortunately we can't get into too much now. Okay, we're going to move on. I know there's a lot of questions around this. Again, we should have a whole 2 hours just dedicated to ventilators, but we can't today. FiO2, I think most people said we would start at 100%, and then based on our SpO2, or if we have blood gases available, we can start to titrate down, remembering that if we give too much oxygen, we actually have those risks of hyperoxia. What about PEEP? Some people, I would argue almost everybody set their PEEP too low. So what we're going to do next is actually go to this respiratory care card. This is the one that I put on the LRC under that paper clip. You can download this. If you're in the Learning Resource Center, you can click on this box and you'll actually be taken directly to it. You can download it onto your phone. It's an excellent, excellent resource. This card is very, very busy. But if you look here at lung protective ventilation, which is this green box here that I'm going to try to center for us. Okay, lung protective ventilation is for all ARDS patients, but also just most intubated patients, even if they don't have ARDS, they benefit from lung protective ventilation. So what is lung protective ventilation? We're going to talk a little bit about ARDS in a minute, but we can start here with tidal volume. And the goal is 4 to 6 milliliters per kilogram. Again, that's predicted body weight. So you want to set your initial tidal volume to that 6 cc's per kg. Remember, you have to calculate predicted body weight. However, they also, if you don't have a calculator, provide you with this table so you can actually look up the size of your patient and then know what the tidal volume is at 4 cc's per kg, 5 cc's per kg, 6, so you can go across here and make adjustments to tidal volume. It talks about plateau pressures and peak inspiratory pressures, which we'll talk about in a minute. We asked about respiratory rate. You want to set your respiratory rate at the pre-intubation respiratory rate. Don't exceed 35 breaths per minute. So again, one person asked, what if the patient's breathing over 35? You set it between 30, 35, but don't go over that because patients are at risk of breath stacking, okay? PEEP and FiO2. You can look down here at this table. There's a lower PEEP, higher FiO2 strategy, and there's a higher PEEP, lower FiO2 strategy. The higher your PEEP, oftentimes the less FiO2 you need. So when we're talking about hyperoxia, we can actually adjust our PEEP to be able to lower our FiO2. So what you need to do is actually look at these tables. So if you're setting your FiO2 at 100%, your PEEP is going to be up to 18 to 24. That's quite high and much higher than a lot of people answered in the chat box. Once you set that, if the SpO2 goals are fine, then you can start titrating down. The goal FiO2 really is less than 60% to avoid hyperoxia complications. So again, this is in the Learning Resource Center. You can either click here, you can click on the link here, or you can use this paper clip and download that respiratory card here. Especially for trainees, especially on your ICU rotation, I highly recommend that you use this respiratory pocket card. Okay, so hopefully that answered most of the questions. Francoise, do you mind reading recommendation number 49? Again, this comes directly from our guidelines.
All right, so for adults with sepsis induced ARDS, we recommend using a low tidal volume ventilation strategy, which means 6 mL per kg, over a high tidal volume strategy, more than 10 mL per kg.
This recommendation has been around since 2000. The initial ArdsNet study was done in 2000, which seems like a very long time ago now. Okay, this next question, I'm going to ask Dr. Radiography if she doesn't mind to answer. Or to ask, rather.
So true or false? ARDS can be diagnosed
without
arterial blood gas analysis. Is it true or false? So you can answer in the chat box.
I expect everyone from Rwanda to get this answer correct. Every single person from Rwanda. I know there's a lot of you there. You were the biggest group last time on Monday. It was mostly Rwandese, so this time you better get it correct. Murakoze, Porjin. And Olivier? Okay, wonderful. Most people said true, but there's some people, 23%, who said false. Redia, did you know that Francoise knows all about the answer?
She does, I'm sure, because the recommendation came from also from Rwanda, isn't it?
It is. Maybe you and Francoise can help us understand what the Kigali modification is to the definition, to the Berlin criteria of ARDS. And again, you can see it here in this chart. You can click here, you can click on the chart itself. It takes you directly to the article. So let's talk about this for just a moment.
All right, so may I start?
Please.
Okay.
Yes.
Yes. So if you look on this Berlin criteria, this is a criteria which is from like 2012, I think, from expert people trying to define what is ARDS among the patients who are having respiratory failure. So you can have, we have 5 criteria. One is timing, the second oxygenation, PEEP requirement, chest imaging, then origin of edema. So on the first criteria, you have the onset, which has to be within 1 week. And the second one, oxygenation, which you look for a ratio between PaO2 over FiO2, which has to be less or equal to 300. Then the PEEP requirement, which has to be more than 5. Chest imaging, the patient has to have bilateral opacities, not fully explained by effusion, or rubber lung collapse, or nodule, or just using chest X-ray or CT. Then for edema, actually this patient, you have to exclude anything like cardiac failure or fluid overload. Then when looking these criteria, if you can see and apply to raw resource settings, you can see that this will not be applied to all of the people from resource limited settings. For example, if you look on the second criteria, PaO2 over FiO2, in order to have this, you have to actually to be able to do arterial blood gas, which is not available in all settings. If you look on the fourth criteria as well, and I mean on the third criteria, in order to have PEEP, a patient has to be on ventilator. We know that the capacity of ventilation in resource limited settings is as well low. So that's why amazing people. So Liviero Twagirumugabe, who is my supervisor, my direct supervisor, I'm proud of it. And the colleagues, try to, after this, they said, actually we have, people who are having ARDS. How are we going to diagnose them? Because this is not going to match for like some people, because we don't have ability of doing arterial blood gas or ventilating all our patients in daily basis. Then for these criteria, they replaced PaO2 with SpO2. Then they have taken a ratio of PaO2 over SpO2 over FiO2, which is going to be less or equal to 315. Then the requirement of PEEP was removed. There was another element, if you see on chest imaging. So they were using ultrasound, chest radiography or ultrasound in order to define this. And by using this, they found that you can easily isolate patient with ARDS. And I think even after this was like the first study which came out, pointing out that even if these criteria for diagnosis of ARDS patient from Berre is not applied to our settings because maybe there is limitation of resources, but we can maybe have something which is applied to our resources. And I think after this, there are many other papers which are talking about it.
Mm-hmm.
Maybe I can give the floor to Radiant or Anna just to go on, and if there's something else to tell us. Yeah.
No, I think that
Thank
was
you.
excellent explanation. Thank you. And I think a lot of us are proud if we know the authors of an article. And so we're very proud to know Jit and Tejan. So love the Kigali modification, and it's very practical for us when we're working in limited resource settings. Dr. Radiant, do you mind reading the next case update? Maybe she's having a connection issue. I'll move us along. So you decide on the following ventilator settings: ACVC, tidal volume of 450, which is appropriate. Mr. G is 75 kg. Respiratory rate of 28, FiO2 of 50%, and a PEEP of 8. Mr. G remains stable on mechanical ventilation for 24 hours. His heart rate and blood pressure are stable, but he still requires noradrenaline and vasopressin. His SpO2 ranges between 92 to 94%. He remains on sedative infusions. His SpO2 to FiO2 ratio is calculated at 184. It is determined he most likely has moderate ARDS. 2 hours later, the FiO2 is increased to 90% to keep his SATs above 92. You now conclude Mr. G most likely has severe ARDS. The peak inspiratory pressure is measured at 38. For adults, I'm going to read the recommendation number 50. For adults with sepsis-induced severe ARDS, we recommend using an upper limit goal for plateau pressures of 30 centimeters of water over high plateau pressures. So now we have a measured peak inspiratory pressure, but the recommendation is talking about plateau pressures. So we need to know the difference between peak inspiratory pressure and plateau pressure. Dr. Erica, would you mind to read this next question?
Sure. True or false, the plateau pressure can be measured in spontaneously breathing patients? And you can answer that in the poll.
Okay, so most people are answering false, but there's a significant, at least a third of people saying that you can. Dr. Erica, do you feel comfortable explaining the difference and why plateau pressure cannot? The answer is false.
Sure.
Cannot be measured, yeah.
Cannot be measured in spontaneously breathing patients. Yeah, so if a patient is making an effort on the ventilator and they're not completely essentially letting the ventilator do all the work for them, it can artificially depress your plateau pressure when you measure it. So to get an accurate plateau pressure, you have to perform an inspiratory hold. Usually these patients are in a volume control modality like we talked about. And then you will measure not the peak pressure, but the plateau pressure after that peak. And if the patient is over breathing on that plateau, your number will not be accurate.
Right. So the peak inspiratory pressure corresponds to dynamic compliance. Dynamic means moving. So as the air moves into the patient, it has to go through the breathing tube, through the airways, into the conducting airways, all the way down to the respiratory airways and the alveoli. Anywhere along that course, the air is in movement. The highest pressure seen is peak inspiratory pressure. Plateau pressure is when the air moves in, it's all the way out to the alveoli and it stops. That corresponds to static. Static means not moving, compliance. That pressure, when the air is not in movement, corresponds to more closely to alveolar pressures, which is what we're truly worried about when we talk about barotrauma. So that static compliance or non-moving air is held at the end of inspiration right before exhalation. That's plateau pressure. So plateau pressure gives you a better idea of the pressures in alveoli. And that target is less than 30 centimeters of water in adults and less than 28 in pediatrics. If we're talking about static compliance and air not moving, you do an inspiratory hold on the ventilator. It's just a button and that air goes in and it's held there. If the patient is breathing spontaneously, that air won't stay still. It keeps moving because the patient's breathing. So plateau pressure must be measured in a patient who is heavily sedated or paralyzed and not breathing spontaneously. Okay, let's go to, who should I pick on next? Maybe Radiot again. Do you mind reading this next question?
Not at all.
Thank you.
So Mr. G's parameters are set with the FiO2 at 0.9 and the PEEP at 8 centimeter water. And peak inspiratory pressure is now 38 centimeter of water. And SpO2 is 92%. Which one of the following statements is the most appropriate step in management for Mr. G? A, PEEP should be decreased to 0 in order to decrease the plateau pressure. B, PEEP should be increased in order to decrease the FiO2. And C, tidal volume should be increased to 8 ml per kg of body weight. And D, respiratory rate should be increased to 38 breaths per minute. So you can answer in the poll.
This is a long question, isn't it? So Mr. G's, his FiO2's at 90%, which is high. You know, we want it less than 60% to avoid hyperoxia. The PEEP is at 8, which is somewhat low on those PEEP FiO2 tables. Let's see, peak inspiratory pressure is 38, but we don't know what plateau pressure is. And the SpO2 is 92%, which we want it greater than 94, but which of the following is the most appropriate? So PEEP going down to 0, what do you think about that in order to decrease plateau pressure, Radiot? What do you think about selection A?
The PEEP originally that is set is not even that high. It's 8 centimeter of water. So it might be more important to keep the PEEP in this patient, I would say.
Yeah, the problem with this patient is oxygen, and the two parameters on the ventilator that improve oxygen are FiO2 and PEEP. So we definitely don't want to take away the PEEP. And in fact, the peak inspiratory pressure is 38, but we actually haven't measured the plateau pressure. So we don't even know that it's above 30. You can have a higher peak inspiratory pressure without a higher plateau pressure. So I would say A is incorrect. What about B? Dr. Erica, what do you think about PEEP, increasing the PEEP to decrease the FiO2?
That sounds like a good idea to me. If you remember the little table that matched FiO2s to level of PEEP, the PEEP probably should be much higher, even on the low PEEP arm, at an FiO2 of 90%, like in the 18 range, as long as the patient can tolerate that hemodynamically. Yeah.
I agree with you, and so do 70% of our learners. Tidal volume should be increased to 8 cc's per kg. I don't think we want to do that. We haven't, the two components on the ventilator that improve oxygen are going to be FiO2 and PEEP, and the two things that get rid of carbon dioxide are going to be tidal volume and respiratory rate. And we're not even talking about carbon dioxide in this question, so probably should keep the tidal volume low. Respiratory rate should be increased to 38. We already talked that we don't really want to go up past 35 if we don't have to. So recommendation number 51, for adults with moderate to severe sepsis-induced ARDS, we suggest using higher PEEP over lower PEEP. Dr. Erica just referred to the PEEP tables and the high PEEP arm versus the low PEEP arm, and this is the table that we should use. So if our FiO2 is at 90% here and our PEEP is at 8, what can we look at on this table to determine if we're going to use the lower PEEP arm and our FiO2 is 90%, the minimal amount our PEEP should be is 14. If we're using a higher PEEP strategy, then our PEEP should go up to 22. True or false? For patients without ARDS, tidal volumes should exceed 6 to 8 cc's per kg predicted body weight. We actually already answered this question. The answer is false. Good. We already answered this question when we looked at our respiratory care card. And it says that lung protective ventilation is good for patients with ARDS, but it's probably good for all intubated patients. So I would say the answer here would be false. So I'm going to go ahead and end that poll and just move forward. This shows some bilateral diffuse infiltrates. Looks pretty bad. Okay. For patients with sepsis-induced respiratory failure without ARDS, we still suggest using low tidal volume as compared to high tidal volume ventilation. This is a weak recommendation with a low quality of evidence, but an official recommendation from the Surviving Sepsis campaign. Okay, these next 3 statements, Dr. Erica, do you mind reading them?
Sure. Temporarily raising transpulmonary pressure may facilitate opening atelectatic alveoli to permit gas exchange, but could also overdistend aerated lung units, leading to ventilator-induced lung entry and transient hypotension. The traditional recruitment maneuver, which consists of the application of sustained continuous positive airway pressure, e.g. 30 to 40 centimeters of pressure for 30 to 40 seconds, selected patients with severe hypoxemia may benefit from recruitment maneuvers in conjunction with higher levels of PEEP, but little evidence supports the routine use in all ARDS patients. So we have focused our recommendations to patients with moderate to severe ARDS.
And do you mind continuing through recommendations 53 and 54?
Not at all. So 53, for adults with sepsis-induced moderate severe ARDS, we suggest using traditional recruitment maneuvers. That is a weak recommendation with a moderate quality of evidence. And for recommendation 54, when using recruitment maneuvers, we recommend against using incremental PEEP titration strategy. And that is a strong recommendation with a moderate quality of evidence.
Yeah, so I actually don't use recruitment maneuvers very often in my practice. I'm wondering, Erica, Francoise, Radiography, is that something that you use routinely in moderate to severe ARDS?
In my practice, I don't use it frequently either. I think with a lot of the patients with COVID, we've seen significant barotrauma, and a lot of my patients have had pneumothoraces, so I've been hesitant to try recruitment maneuvers.
Yeah, I've seen that as well, especially with those very non-compliant stiff lungs. Doing a recruitment maneuver is probably not going to, the recruitment is recruitment of alveoli to participate in oxygenation, isn't it? So if you have those very non-compliant lungs. Radiography and Francoise, do you use recruitment maneuvers in your ARDS patients?
Well, in Ethiopia, we don't usually, sometimes we may use recruitment maneuvers when we're in desperate situations, but it might be, the benefit might outweigh the risk, like in the risk of barotrauma, so we don't routinely do it unless we are absolutely, when it's only when it's a must.
Yeah.
But it's not a routine practice.
Right. I think all of us are not doing it routinely, isn't it?
Yeah, for us also, it's not a routine practice. So when you are desperate, you are like, there's nothing else I have to try. Sometimes you try it, but at the end, I don't think there is really, so we don't use it routinely.
Yeah. Yeah, I think it is a bit of a desperation to improve the oxygenation of the patient, but we're all a bit afraid of causing barotrauma. One of the recommendations that's quite striking with strong recommendation and a moderate quality of evidence is not to use the titration of PEEP. And what that means is you apply that 30 to 40 centimeters of water of pressure in a recruitment maneuver over 30 to 40 seconds. And some people were actually then applying very high levels of PEEP after that. So really inflating these lungs. And the studies are actually showing that they have an increased risk of mortality. 28-day mortality went up when you do these PEEP titration recruitment maneuvers. So don't do it. That's easy to incorporate into your practice and change your practice. Don't do it. So it's easier not to do something. Prone positioning, when should it be used, in which patients, and how is it done? So let's start with the first part. When should prone positioning be used? You can put your answers in the chat box. There's no poll question for this. Okay, I'm going to keep us moving so we don't run out of time. This article I just want to point out is about prone positioning and severe ARDS. This is the New England Journal of Medicine. And I really want to point out that this article comes out from 2013. This is long before the pandemic. So prone positioning has been a method that actually has been shown to decrease 28-day and 90-day mortality in severe ARDS for many, many years. So it's not just COVID for which prone positioning has been used. So in which patients? For adults with sepsis-induced moderate to severe ARDS, we recommend using prone ventilation for more than 12 hours daily. The initial study used it for greater than 16 hours per day. And it's any patient with moderate to severe ARDS. I think in clinical practice, most of us have been using prone positioning as much as possible. We've been using it in the non-intubated patient on oxygen masks or high flow oxygen. If you have the patient roll themselves over onto the prone position, their oxygenation will go up. Similarly, it has been demonstrated to be a safe technique in patients who are intubated. And I've given you some resources here that explain how to do prone positioning and also a video to watch. So a quote from the guidelines says that in patients with ARDS and a P to F ratio less than 200, we use prone compared with supine within the first 36 hours of intubation when performed for greater than 12 hours a day, and it improved survival. That's the gold of patient care, is improving survival. So here they say, use it early. Within the first 36 hours, start proning your patient. And they also say P to F ratio less than 200. If you don't have access to the PaO2 or arterial blood gas analysis, you can use your SpO2 to FiO2 ratio. So once your patients enter that moderate to severe category, start proning them. Here's one example. I'm not necessarily saying this is the only checklist there is out there, but it's really, really important to be systematic and deliberate when you prone intubated patients. Because there's so many wires, tubes, drains, there's a high risk of dislodging tubes, dislodging drains, also a higher risk of pressure sores on the face and on the rest of the body. So you have to be very careful on how you prone these patients. It does take increased numbers of people. So oftentimes there's 5 or 6 people at least, with one person dedicated to the airway. So you have to be very careful. So this is an example of a prone ventilation checklist. You can download this, you can click on here, you can click on there, you can download this and then adapt it to your setting. So this is a very easy way to incorporate prone positioning into your practice. Remember, we don't want to just learn about this stuff. We want to implement it in our practice so that we can help save patients' lives. Can't go through this because of the limitations in time, but this is an excellent, excellent video. It's about 5 minutes long about
proning an ARDS patient.
About how to prone your patient. So you can just click on this video and watch it, and it goes step by step by step on how to do that safely in this intubated patient with all of these tubes, drains, lines, etc. So this can be found on the Learning Resource Center and then also on on the internet, obviously. Okay, ready? Can we do some more questions?
Can I, sorry.
Oh,
Can I
yeah,
interrupt you, Anna?
of
So,
course.
what do you say about prone position in our settings? Like if you have one nurse for 2 patients, do you think is prone position going to be like easy and safe?
Yeah, so those ratios, those nursing ratios, 1-to-1 or 1-to-2 are standard ICU ratios. So it's not just your setting, it's my setting too. Even though we have more resources, we don't have more human resources. And so what ends up happening is all of the nurses set up a time. And so they make sure their patients are taken care of, and they set that time with the airway doctor or present. And at that point, all the other patients are safe. The act of turning a patient from supine to prone should really take less than 10 minutes. It's just that you have to use the checklist to make sure everybody understands their role, that safety comes first. Then the team gets together, they turn the patient, then they go back to care for their own patient. So it really shouldn't take very long. And it's definitely safe in all settings. It doesn't require special equipment. All of us have had to learn and train on our own. We just have, done some of this research on how to do it. So it's definitely applicable in every setting. You just have to have all your nurses trained. And that should really come from the top. That should come from the physician leads, and just making sure airways are not displaced and central lines are not displaced and IVs and Foley catheters are not displaced. So that's the most important thing. Watching that video, you can see that team really come together, and they do a great job of communicating. It's all about communication and safety. I answered your question, I hope.
Yes.
Okay, good.
Thank you.
Taki Basil.
Okay. I will continue then.
Yes, thank you, Ready.
So the case updates. So Mr. G has severe ARDS. He sedated, you have increased the PEEP to 20 and the FiO2 is now down to 60%. You measure a plateau pressure and it's 36 centimeter water, and you remember the goal plateau pressure should be less than 30 centimeter water.
That's not uncommon. So, obviously, if we increase our PEEP, our plateau is also going to rise. So now we have to remember, like, oh, geez, we're supposed to keep our plateau less than 30. How do we do that, right?
Yeah. So yeah, which one of the following strategies can be used to decrease the plateau pressure? A, deepen the sedation. B, decrease tidal volume from 6 ml per kg to 4 ml per kg. C, administer a neuromuscular blocking agent. And D, all of the above. So you can answer the poll.
The good thing about this question, Rodiat, is if you answer any of them, you get it correct, isn't it? Because the answer is D, all of the above. Great. So 75% of people said all of the above, which is correct. So ways to decrease the plateau pressure is to decrease that thoracic pressures. And so you can do that by relaxing the muscles. So a neuromuscular blockade agent or deepening sedation. And then also decreasing the tidal volume from 6 to 4 will also decrease your plateau pressure. Okay. Ready? Do you mind reading number 56, please?
No. So for adults with sepsis-induced moderate severe ARDS, we suggest using intermittent neuromuscular blocking agent, boluses, over neuromuscular blocking agent, continuous infusion.
This is a practice change for me. What about you, Radiant?
We don't usually use infusion agents because of shortage of these drugs. We usually give bolus.
You usually give a bolus. What is your practice, Dr. Erica?
I think most of the time, we'll try a bolus to see if that gets our desired effect. And then if the patient's oxygenation improves with the initial bolus and then worsens as it wears off, we'll put them on an infusion. But it should be a time limited infusion. Usually we'll then try to wean off the infusion after 48 hours. But I think probably the point to the guideline is just it's probably not a good thing to keep people paralyzed for very long periods of time.
Right, right. Dr. Francois, do you use infusions or boluses for neuromuscular?
Both of them.
Both.
Yeah, both of them. Sometimes you start by boluses, that doesn't work. We just go to infusion, as like the guidelines, the guideline which was there. That's what we were following.
Yeah.
Now I think we have to change. So we have to change actually.
Yeah,
I
think I need to change in my practice as well. We have done some bolusing, but we've relied very heavily on infusions. And so I think the point is really to use the intermittent boluses as much as possible and try to avoid the infusions. And this is an algorithm that helps walk us through that. So moderate to severe ARDS, can you achieve lung protective ventilation with light sedation targets? If yes, then don't even use muscular blockers. If they have light sedation and you give them deep sedation, and you can achieve your lung protective strategy with intermittent boluses, then stay there. If you can't, then you might want to look at the infusions. But if you do an infusion, they want you to turn it off after 48 hours. And the reason for that is these neuromuscular blockers, especially in the setting of critical illness, can really worsen critical illness, neuropathy, and myopathy. And patients after being critically ill are profoundly weak anyway, so this actually makes it worse. And we're going to talk a lot about what happens after ICU care. So decisions we make and treatment that we offer and implement in the intensive care unit or anywhere when patients are critically ill really has an impact on when they leave the ICU. And so we really need to be conscious of this. If somebody's profoundly weak after being in the intensive care unit for a long time, and then they get better and they go home, they have months to years of rehabilitation. And that has a dramatic impact on their families, on their ability to work, and those types of things. So we really want to be cognizant that the decisions we make for patients really do have long-term effects. Okay, I'm going to just read through this next section. This is VV ECMO is not available in many settings. I think Dr. Erica has access to VV ECMO, but in my practice, I even don't have access to VV ECMO. But it's something that we should all know about. So the recommendation number 57 from the guidelines, for adults with sepsis-induced severe ARDS, we suggest using veno-venous ECMO, which is extracorporeal membrane oxygenation, when conventional mechanical ventilation fails in experienced centers with the infrastructure in place to support its use. So even in my setting, I don't have access to this. I would have to refer my patient to another institution in order to get this for a patient, which I have done throughout the pandemic. This image was done by this Dr. Kathy, and she has done a really beautiful job, I think, of illustrating veno-venous ECMO. And what happens is you have a very large venous cannula. This is in the inferior vena cava. It pulls blood, so inflow, drainage from the patient, puts it through a pump that goes to an oxygenator. This is just like cardiac bypass. So essentially they introduce oxygen to the blood, and then that blood is reintroduced into the superior vena cava, so veno-venous ECMO. And what happens is it oxygenates the blood and bypasses the lungs that are not working because of severe lung damage because of the ARDS. So some people will recover from this, other patients won't. Some people need lung transplants, etc. So veno-venous extracorporeal membrane oxygenation is used in patients with severe acute respiratory failure to facilitate gas exchange in the setting of refractory hypoxemia or hypercapnic respiratory acidosis. The evidence in this guideline was downgraded to very low quality due to indirectness. There were methodological limitations of the included studies. So this just means that our evidence base is not solid. In clinical practice, patient selection is important and usually discussed prior to initiation of ECMO at an ECMO center. So not all hospitals are ECMO centers. Cost and equity are substantial issues. It's very, very, very expensive. And registry data will be very important to document longer-term outcomes in these patients outside of the clinical trial context. So cost and equity is an important thing. It's very, very expensive to use VV ECMO or ECMO of any kind. In healthcare settings like in the United States, where people have to pay for their own health insurance and it's not provided for everyone equally, it creates an ethical dilemma because it requires only people with money will have access to this. So there's a lot of issues around ECMO. We're going to move on now to additional therapies, and I'm trying to move us through quickly because we're running out of time. But I will get Dr. Erica to read our next set of learning transfer that leads to practice change objectives under additional therapies.
Okay. Know when corticosteroids are indicated in septic shock. Describe when blood purification techniques are indicated in sepsis and septic shock. Understand when blood transfusions are indicated in septic shock. Describe when IV immunoglobulins are indicated in septic shock. List the risk factors for stress ulcers. Recite the recommendations regarding pharmacological and mechanical venous thromboembolism prophylaxis for patients in septic shock. List the target blood glucose range for critically ill septic patients. Understand when to use vitamin C in septic patients. Initiate bicarbonate therapy in the appropriate clinical context. And recite when to start enteral nutrition in patients with septic shock.
Great. So this is a very high yield section. So we spent almost the entire part of the first webinar talking about resuscitation and vasopressor support and fluid resuscitation. Now we spent all this time on ventilation and ARDS, but a lot of these things are the additional therapies that we need to consider. And in fact, last time we had several people ask us about steroids, blood transfusion, etc. So I'll go ahead and read the case update. You return to work the following day. Mr. G is now in supine position after being in prone position for 16 hours. He's sedated on midazolam and hydromorphone. He's received intermittent boluses of cisatracurium, monitored for a goal of 2 out of 4 twitches on a nerve stimulator. He has coarse bilateral breath sounds. He's on ACVC, tidal volume of 6 cc's per kg, respiratory rate of 35, a PEEP of 20, and an FiO2 of 60%. His peak inspiratory pressure is 35, and his plateau pressure is at goal. It's at 30. His SpO2 is 94, which is also at goal. And his SpO2 to FiO2 ratio, using Kigali modifications, is 157. He's still a bit tachycardic with a heart rate of 108. His blood pressure is a little bit low, so 90/46, and that MAP is less than 65. And we know that our MAP goal is 65 and above. And that's despite being on a noradrenaline infusion at 0.7 mics per kg, which is quite high. And also with vasopressin running at 0.04 units per minute. So he's on max doses of both of these infusions and still has hypotension. He has a Foley catheter, a gastric tube, an endotracheal tube, an arterial line, a central venous catheter, and 2 peripheral IVs. His full blood count reveals a white blood cell count of 27, a hemoglobin of 8, platelets of 280. His chem panel is remarkable for a very slightly high sodium, slightly high chloride, low CO2, and some renal insufficiency. He also has a blood glucose of 240. And his lactate is still elevated at 3.5. Francois, do you mind reading this next question, please? Dr. Francois? Okay, how about Dr. Rediet?
Okay.
Thank you.
Mr. G's is 61 millimeter mercury despite 2 vasopressor infusions, noradrenaline and vasopressin. Which one of the following is the next best therapy to initiate for support of his blood pressure? A, add adrenaline infusion. B, IV corticosteroids. C, replace noradrenaline with tartracin infusion. D, A and B, and E, talk to the family and withdraw care. So you can answer in the poll.
Yeah, I see the poll numbers going everywhere. It's great. Okay, we'll stop there. I think the answer is D, A and B. So we'll scroll down, and Dr. Reddiot, if you don't mind to continue to read the recommendation, number 58, and then the 2 quotes. These are recommendations 39 and 40, which we have already discussed, but just as a reminder.
Okay. For adults with septic shock and an ongoing requirement for vasopressor therapy, we suggest using IV corticosteroids. The typical corticosteroid used in adults with septic shock is IV hydrocortisone at a dose of 200 milligram per DL and given as 50 milligram intravenous every 6 hours or as a continuous infusion. It is suggested that this is commenced at a dose of norepinephrine or epinephrine greater than 0.25 microgram per kg per minute at least 4 hours after initiation. So that is a recommendation.
Right. So if you're on 2 pressors and you're still hypotensive, then you need to consider IV corticosteroids. So great. We're going to do the right thing.
Yes. So for adults with septic shock and inadequate mean arterial pressure levels despite norepinephrine and vasopressin, we suggest adding epinephrine.
Yeah. And so epinephrine is the same as adrenaline. So because Mr. G's already on noradrenaline and vaso, adding that epinephrine will also help to augment blood pressure, assuming he's volume replete. And so adding steroids is great, but it takes a while for the steroids to start working. So you still need to add an additional pressor in the meantime.
Yes. So for adults with septic shock, we suggest against using tartracin.
Yeah, we don't have that in our setting either. So, so we can't use it, which is good because it's not supposed to be used. Okay. Mr. G is critically ill. He's in septic shock. He has ARDS. He's on very high settings on the mechanical ventilator and was requiring 3 vasopressor drips. He has a hemoglobin of 8. Your student asks you, why do you not give him a blood transfusion? Will that not increase both his oxygenation and his blood pressure? Will you transfuse Mr. G? I love this question. It's almost 50-50, isn't it? Okay, the answer is no, you don't need to transfuse Mr. G. There's been multiple studies around blood transfusions, and recommendation number 60. For adults with sepsis or septic shock, we recommend using a restrictive transfusion strategy, so not a liberal transfusion strategy. This is a strong recommendation with moderate quality of evidence. A restrictive transfusion strategy typically includes a hemoglobin concentration of 70 grams per liter. Red blood cell transfusion should not be guided by hemoglobin concentration alone, but assessment of the patient's overall clinical status and consideration of extenuating circumstances, such as active heart attacks, severe hypoxemia, or acute hemorrhage. So for many years, we've used the TRICK trial, which is transfusion in critically ill patients. And it really changed the way people were using blood transfusions. And so most of us will only transfuse a patient if their hemoglobin is 7 or less, or 70 or less, depending on what units you use in your lab. So there are risks to giving blood. There's a lot of complications that can happen when giving blood. So you always have to weigh the risks versus the benefits. And the risks can be high, and the benefits have not been shown to be that great unless that hemoglobin goes below 70. And so the mortality didn't change, but with the liberal transfusion strategy, and there was a higher incidence of complications. So a restrictive strategy was determined likely beneficial with regards to resources required, cost effectiveness, and health equity considerations. The restrictive strategy is feasible in low and middle income countries. The 2016 strong recommendation favoring restrictive strategy is unchanged. However, the overall quality of evidence changed from strong to moderate. Basically, they went back through all of the literature and reviewed all of the studies, and there was one study that was a little bit questionable, so that's why it moved from strong to moderate, but still a strong recommendation overall, not to transfuse patients unless that hemoglobin drops. This is for the setting of Mr. G, but if you had somebody who had ongoing bleeding, for example, if he developed a GI bleed or some other complication or DIC, then you would reconsider transfusion. But for someone who's not actively bleeding, you don't need to transfuse. Okay, this is a nice game we're going to play. So for each one of the following therapies, state whether it is or is not a current recommendation for adult patients with sepsis and septic shock according to the guidelines. So is it a recommendation? Is yes. Is it not a recommendation? Then you say no. So polymyxin B hemoperfusion, yes or no. Stress ulcer prophylaxis, yes or no. IV immunoglobulins, yes or no. Blood purification techniques, yes or no. Vitamin C, yes or no. So this is a longer poll, so I'll give you a little bit more time, but this goes through several of the key recommendations really, really quickly. This is great to watch these polls unfold. Okay, that's been 1 minute, so we're going to end there. Polymyxin B, 79% said no, and that's correct. It has no role in sepsis or septic shock. It's not a current recommendation. Very proud of all the learners for number 2. Stress ulcer prophylaxis is definitely required and recommended. Number 3 was almost a 50-50 split, but the current recommendation recommends against using IVIG for sepsis and septic shock. Similarly, blood purification techniques are not recommended, and that was another 50-50 split. So these questions that have half people answering one way and half people answering the other way, I see as opportunities to change your practice and your knowledge. So vitamin C was 60-40. The answer is actually no. Vitamin C also has no role in sepsis or septic shock. So we'll go through those recommendations. Number 59, we suggest against polymyxin B hemoperfusion. Number 62, we suggest against IVIG or intravenous immunoglobulins. Number 63, for adults with sepsis or septic shock and who have risk factors for GI bleeding, we suggest using stress ulcer prophylaxis. Number 70, we suggest against using IV vitamin C. So remember, these guidelines come out of a global consortium of experts who scour all of the literature, all of the studies in order to weigh the risks and benefits of each one of these recommendations. So they've looked through all the evidence and have determined these recommendations from that. So yes on stress ulcer prophylaxis and no on everything else. So pretty interesting if you're using those in your practice, which I wasn't, but you might want to reconsider that. Okay, I know there was actually a trial, one of the trials was being done in Rwanda around vitamin C, if I recall, but that has been disproven. So, okay, how about Dr. Erica again? Can you read this next question for us, please?
Sure. Which one of the following is the most appropriate prophylaxis against venous thromboembolisms? A, serial compression devices, which are like things that squish your calves. B, pharmacologic Vte prophylaxis. C, serial compression devices plus pharmacologic Vte prophylaxis. Or D, compression stockings only. Let's see.
I like this question too, because I think there's a lot of confusion around this.
I think we don't always do this correctly.
No.
So it looks like about 2/3 of people said serial compression devices plus pharmacologic Vte prophylaxis, and about 1/3 said pharmacologic Vte prophylaxis.
Oh no. Oh
Yeah.
no. So 2/3 of people actually answered incorrectly. The answer.
But that's what we do wrong too.
I know. So it's actually B. You don't need to use the SCDs or serial compression devices. So for adults with sepsis or septic shock, we recommend using pharmacologic prophylaxis unless a contraindication to such therapy exists. So the contraindications for Dbt prophylaxis are actually not very many. So ongoing bleeding, and then oftentimes if you had an intracerebral bleed, that would be a contraindication. If there was an allergy to one of the medications, that would be another one. But even in surgical patients, we will often give DBT and PE prophylaxis. So it really is strongly encouraged to use that. We recommend using low molecular weight heparin over unfractionated heparin for DBT prophylaxis. I think one caveat with this, and Dr. Erica, I'd be curious to see if this is how you think as well, but when people have renal dysfunction, we will tend to use heparin instead of things like Lovenox or low molecular weight heparin.
Yeah, definitely. Like at a creatinine clearance of around 30 or below, I would switch to heparin.
Yeah. So for patients with sepsis or septic shock, we suggest against using mechanical VTE prophylaxis in addition to pharmacologic prophylaxis. And that's a weak recommendation with low quality of evidence, but they're basically saying if you're on medication prophylaxis, you don't need to also put on serial compression devices. Olivier, the serial compression devices are these sleeves that you put on the lower leg of the patient, and they're connected to a machine and they squish the legs. So serial compression of the legs, and we use them in the operating theaters often. But it basically keeps the blood flow moving so that it's unable to clot in paralyzed, sedated, or bedbound patients. So what this recommendation is saying is that if you're using pharmacologic prophylaxis, such as low molecular weight heparin or heparin, unfractionated, you don't need to use those compression devices as well. A low platelet count. This is a great question from Yunusa. A guide to pharmacologic DBT prophylaxis. So I'll maybe let Dr. Erica address this as well, but in general, no. Even with low platelet counts, patients can still develop DBTs and PEs. So the platelet count would have to be profoundly low in order for us to withhold that prophylaxis. Dbt prophylaxis is lower dose, so it's doesn't have the propensity to make people bleed. So it's really only patients that have active bleeding in which we stop that. We do a tremendous amount of blood cancers, so leukemias and lymphomas at Stanford. And often these patients have undergone chemotherapy. And so their platelet counts can be quite low. So I would say if the platelet count is greater than 10 to 20, you would continue to use your DVT prophylaxis. Erica, do you have thoughts around that?
No, yeah, I agree with that as well. I definitely, if we weren't talking about prophylaxis, if we were talking about full anticoagulation, you certainly would want to be cautious below a platelet count of 50, but it's much safer with just the lower dose prophylactic dosing.
You're welcome. Okay. True, false, continuous. Oh, I better not give you the answer. True, false. Continuous renal replacement therapy demonstrates an improved mortality benefit over intermittent renal replacement therapy. So hemodialysis continuous versus intermittent, which one has a mortality benefit? I don't know why it's so fun to me to watch these polls to see what learners are thinking so that we can discuss it. It's fun. Okay, we can close that one. It's 50-50 split, I'd say. Okay. Dr. Francois, are you using continuous or intermittent hemodialysis in your institutions? I can't hear Dr. Francois. Is that maybe her connection is poor?
I think we lost her, yeah.
Oh, did we? Okay, unfortunate. So 2 systematic reviews and a meta-analysis summarize the total body of evidence. They do not show a difference in mortality between intermittent or continuous. So if you're practicing in a setting where you don't have continuous renal replacement therapy, don't worry, you can still use intermittent hemodialysis if that's available. That's actually my practice setting as well. I don't have access to continuous. Okay, Dr. Reddiot, do you mind doing the next one?
Not at all. In septic shock, which one of the following is an indication for renal replacement therapy? A is oliguria, 0.3 ml per kg per hour for greater than 24 hours. B is anuria for greater than 12 hours. C is serum creatinine greater than 3 times baseline with rapid increase of 0.5 milligram per deciliter. D, all of the above are indications for dialysis. You can answer in the poll.
Great. I think almost everyone answered correct. Reddiot. The answer would be D, all of the above.
Yeah.
Okay. Do you want to read the 2 recommendations, 67 and 68 for us?
Sure.
Thank you.
In addition, with sepsis or septic shock and AKI who require renal replacement therapy, we suggest using either continuous or intermittent renal replacement therapy. In adults with sepsis or septic shock and AKI with no definitive indication for renal replacement therapy, we suggest against using renal replacement therapy.
Wonderful. Okay, let's talk about blood glucose. Mr. G's blood glucose is 240. Will you start insulin on him? This is so great. It starts out yes, and then it's no, and then it's yes. The answer is yes. We would want to control his blood glucose. So which one of the following is the most appropriate glucose target for adult patients with septic shock? So is it less than 300, 144 to 180, 110 to 144, or less than 110? Which of these is our goal for septic shock patients, critically ill patients? Protogen, you're making me so proud. And Isabel. Kashem, good. Olivier, good. Wonderful, you guys got the answer correct. So it's B, 144 to 180. They did studies which showed tighter glucose control, such as 110 to 144, and they actually had worse incidence of hypoglycemia, which is sometimes worse than hyperglycemia. So the risk of keeping tighter blood pressure control was too high and outweighed the benefits. So really 144 to 180. And everyone answered correct. I'm proud of you guys for that. So adults with septic shock recommend initiating insulin therapy at a glucose level that's greater than 180, which Mr. G's 240. It's a strong recommendation with moderate quality. Following the initiation of insulin, a typical target blood glucose range is 144 to 180, or 8 to 10 millimoles per liter, depending on the units you use in your laboratory. The nurse calls you with an update and new labs. She states, Mr. G has had 0 urine output for 12 hours and arterial blood gas results are back from the lab. The pH is 7.14, CO2 is 34, bicarb is 11, and PO2 is 55 with a base excess of negative 17.4. Do you want to give this patient bicarbonate? It looks like a 50-50 split so far. So this is so I just got a direct question. In a setting where we have neither norepinephrine or vasopressin, what's the ideal vasopressor? So norepinephrine is the same as noradrenaline. If you don't have noradrenaline, you can just use adrenaline. However, the society recommended that your system try to access noradrenaline. So you might want to advocate for your patients and try to get noradrenaline available in your facility. Okay, so Dr. Eric, I'm going to ask for your help on this one with the bicarbonate. Do you mind reading 71 and 72? The answers are about 50-50. Some people said yes, some people said no. Yeah. This is actually a difficult question and one where I have to evaluate my own practice as well.
Yeah. 71 for adults with septic shock and hypoperfusion-induced lactic acidemia. We suggest against using sodium bicarbonate therapy to improve hemodynamics or to reduce vasopressor requirements. That's a weak recommendation, low quality of evidence. For 72, for adults with septic shock, severe metabolic acidemia, pH less than 7.2, and an AKI, we suggest using sodium bicarbonate therapy. That's also a weak recommendation, low quality of evidence. So it seems like if your patient has acidemia that is related to their renal impairment, it's indicated to start them on bicarbonate.
Yeah.
But less so, and I will say I probably have started someone on a bicarbonate drip who had severe lactic acidosis as a stopgap, but I will update my practice too.
Yeah, I think you and I probably practice similarly since we're in similar practice settings, but the thinking and the way that I was trained was once your pH becomes very, very low, at what point is low? I would say probably 7.15, something like that. You need to remember that your catecholamines, your vasopressors, are actually working on enzymatic processes. And if you remember when you were in school learning about enzymes, enzymes only work in very narrow range of temperature and pH. So when your pH is very, very low, these processes start to break down. And so when someone is profoundly acidemic, and they're on vasopressors, those vasopressors may be less effective. And so this is weak recommendation with low quality of evidence, but they're saying don't just start bicarbonate therapy to improve the effectiveness of your vasopressors unless the patient has concurrent kidney injury. I think at that point, most people have kidney injury anyway. So we probably don't have to change our practice too much, Erica, but I think it is good to remember that if the kidneys are working, they really are responsible for managing the bicarbonate. So overall, the quality of evidence is low. This is moving on. Sorry, this is about the same thing. Summary of judgment supported a weak recommendation against bicarbonate. The 2016 recommendation is essentially unchanged. However, considering patients with septic shock, severe metabolic acidosis, and acute kidney injury, the balance of effects probably favors IV bicarbonate. A weak recommendation for the use of IV bicarbonate in this population was made. So it's not strong evidence either way, but I think if I had somebody who is profoundly acidotic with acute kidney injury and on multiple pressors, I would try to give bicarbonate to get my pH to back up to greater than 7.2. That would be how I would incorporate that into my practice. Anybody else have thoughts about that? Okay, we'll keep going since we're running out of time. Number 73, recommendation for adult patients with sepsis or septic shock. We suggest feeding your patients early. Give your patients nutrition. Their bodies are working really hard to fight infection and to heal. So within 72 hours, try to give enteral nutrition. There's a huge document of guidelines regarding nutritional support in adult critically ill patients. It comes out of the Society of Critical Care Medicine as well as the Society for Parenteral and Enteral Nutrition. Both of these are primarily based in the United States. This again would be another 2 webinars because it's such a large guideline, but it's available to you here. You could just click on this and download those guidelines as well if you needed. I'm going to move quickly through the next section since we're out of time, but long-term outcomes and goals of care. I alluded to this earlier in that decisions we make about caring for our patients that are critically ill have long-term effects on the patients and their families. And so we really need to be aware of this so that we can make better decisions for our patients. So we need to address early the goals of care for patients in the intensive care unit who are critically ill. We want to integrate principles of palliative care into caring for patients that are critically ill, and we want to develop and implement formalized handoff processes. So patients who survive a long period of ICU care for sepsis typically face long and a complicated road to recovery. There will not only be physical rehabilitation challenges to overcome, but also great uncertainty about the way to organize and coordinate care, to promote recovery and avoid complications, recurrence, and to ensure care is matched to patient and family goals of care. If somebody is very critically ill and near death, it really is important to honor patient autonomy. It's really the patient's choice as to what interventions are received. Some patients may not want, especially if they're chronically ill and older, and then critically ill, may not want everything done. So for adults, we recommend discussing goals of care and prognosis with the patients and families. So don't ignore goals of care and the prognosis. It's really better to have open communication with patients and families about what's happening. We suggest addressing goals of care early, within 72 hours over late. Medical ethics is a well-established field of study, and it has some pretty definitive recommendations. However, every culture is different, every country is different, every patient and family is different. So we really need to be respectful, but it's better to have discussions about decision-making than to not have those discussions. Okay. Patients with sepsis or septic shock are at high risk of multi-organ failure, long-term functional sequelae, and death. Some patients may accept any and all treatments for their condition, but others may consider limitations depending on prognosis, invasiveness, and predicted quality of life. A discussion of goals of care and prognosis is essential to determine which treatments are acceptable and those interventions that are not desired. It's all about what the patient wants. They recommend integrating principles of palliative care into our practice, into the treatment plan, and to address patient and family symptoms and suffering. They suggest against consulting palliative care for all patients, but just patients where it might be needed. So for those of you that may not have practiced with palliative care specialists available or have not read much about palliative care, this is an article that I found for you that just outlines the principles of palliative care. You can click on the article and read more. But the general principles, communication, symptom diagnosis and assessment, pain control, emotional care, social issues, spiritual and existential issues, grief and bereavement, the relatives, including children, and the needs and support of the team caring for the patients, staff stress and burnout, ethical issues, emergencies and how they're dealt with, and then the legal requirements and norms of palliative care. So this is a whole nother specialty of medicine that needs to be explored and incorporated as much as we can into our care plans. For adult survivors, we suggest referral to peer support groups if they're available. So patients often suffer not only physical harm, but emotional harm. And so it's great to have them surrounded by people that understand what they're going through. They suggest using a handoff process for critically ill patients. So if you're transferring care from one physician to another or from one institution to another, it's really important to have formalized systematic handoffs so that important information at those transitions is not lost. So transitions of care are prone to communication errors, which have been identified as a barrier to the timely detection and management of sepsis. Improving handoff at transitions in care represents an opportunity to improve patient outcomes. This is an improvement in our practice. Incorporate this into your practice. And it applies across the entire spectrum of sepsis care, from hospitalization to return to the community. Structured handoff processes appear to result in more complete and accurate transfer of information. So I'm going to ask you this question. Which of the following is recommended support for patients and families dealing with critical illness? Screening for economic support, screening for housing, financial, and spiritual support, providing written and oral education about sepsis, inviting the family to participate in shared decision-making, or all of the above. And I can already see that almost everybody's answering all of the above, which is the correct answer. Great. So the recommendations basically say that same thing. You want to screen for economic and social support. You want to provide written and verbal education materials to the patient and their families. And you want to present opportunities for the families to actually participate in some of the decisions. Okay, 2 weeks passed. Mr. G is slowly recovered. He's now off vasopressor infusions. He's ready to extubate and liberate from mechanical ventilation. You inform his family that you anticipate his continued improvement and discharge from the ICU in approximately 1 to 2 days. Once the patient recovers and is discharged from the ICU, your responsibilities cease. True or false? Wonderful. So we really need to recognize that the decisions we make in intensive care with critically ill patients translate to after critical care. So we can help patients and families through that recovery process. Which of the following is not a common impairment following prolonged critical illness? Readmission, physical disability, anxiety and depression, cognitive dysfunction, neuropathy and myopathy. Or F, all of the above are associated with prolonged critical illness. You guys are doing great and answering all these questions correctly. And I think this is an intersection of when we know what the right thing is to do versus actually incorporating it into our practice. So that's correct. All of the above are complications of ICU. So we need to be cognizant that some decisions we make in the ICU can impact patients afterwards. Okay, Dr. Erica, will you read the case update, please?
Sure. 1 year later, Mr. G and his family returned to the hospital. He is ambulating independently. He works with physical therapy 3 times per week, and he just went back to work last week. Mr. G and his family visit the ICU and thank you and the entire ICU team for their excellent care.
And Radiot, do you mind reading our closing quote, please?
Not at all. Not everything that is faced can be changed, but nothing can be changed that's not faced. That's written by James Baldwin.
Wonderful. So there's a lot of information in these updates and guidelines, and I encourage you all to go onto the Learning Resource Center and you can review what we talked about today. You can access all of those articles that are free and open access. You can download slides if you want to teach others and help them also improve their practice around sepsis and septic shock. I want to thank you to my co-panelists that did an amazing job. Thank you for that. And also thank you to Alana, who I can't live without, from Assist International, who helps with all of the coordination of these sessions. And thank you to all the learners who are trying really hard to change their practice to improve their patients' lives and outcomes. So with that, we will end. Thank you so much.
Thank you.